Pelvic pain that is reliably worse when you sit, and that does not wake you at night, fits a recognizable pattern. It is counterintuitive. Pain that lets you sleep sounds like it could not be a serious nerve problem. In pudendal neuralgia, not being woken at night is one of the 5 criteria that supports the diagnosis. Pudendal neuralgia means pain in the distribution of the pudendal nerve. It has a formal set of diagnostic criteria, agreed by a working party, and known as the Nantes criteria. Knowing them is genuinely useful because this condition is diagnosed clinically rather than by a scan. The Nantes criteria set out 5 essential features. First, pain in the anatomical territory of the pudendal nerve. Second, pain worsened by sitting. Third, the patient is not woken at night by the pain. Fourth, no objective sensory loss on clinical examination. Fifth, a positive response to an anesthetic pudendal nerve block. 2 of those are counterintuitive, and they are worth dwelling on. Not being woken by the pain is a positive criterion. It is not evidence against the diagnosis, and no objective sensory loss on examination is expected, which means a normal neurological examination supports the diagnosis rather than undermining it. That second point matters because of how these appointments usually go. You describe pain that is worse in a chair. Someone tests sensation, finds it normal, and the conversation moves on to something else. Under this framework, a normal sensory examination is part of the pattern, not the end of the discussion. The same working party also proposed exclusion criteria. These are the features that argue against the diagnosis. Pain that is purely coccygeal, gluteal, or hypogastric. Pain that is exclusively paroxysmal, exclusive itching, and the presence of imaging abnormalities capable of explaining the symptoms. That last exclusion is the discipline of the whole framework. If a scan shows something that accounts for the pain, that finding takes precedence over a clinical pattern. The criteria are not a way of talking past your imaging. They are a way of reasoning carefully when the imaging is clean. Which brings up the harder point. The diagnosis is essentially clinical. There are no pathognomonic criteria, and there are no specific clinical signs or complementary test results for this disease. What the working party says is that a combination of criteria can be suggestive. Suggestive is the honest strength of that claim, and it should not be inflated into certainty. This is why people with pudendal neuralgia so often accumulate a thick folder of normal investigations, and with that folder, the impression that nothing is wrong. Normal results are consistent with the diagnosis. They are not a refutation of it. If you have been told repeatedly that everything came back fine, that sentence is not the same as an explanation. The 5th criterion deserves its own moment, which makes the block part of establishing the diagnosis rather than only a treatment. A subsequent review notes that the Nantes criteria gives structure to the diagnosis, and it recommends a stepladder approach to therapy. At the Padda Institute, diagnostic and therapeutic blocks are described under nerve blocks, where a neighboring nerve is the actual source. Cluneal neuropathy and piriformis syndrome become relevant. For refractory cases, peripheral nerve stimulation is among the options. And because persistent pelvic pain carries a heavy psychological load, counseling for chronic pain is delivered in-house here. A few questions come up almost every time this is discussed. Does pudendal neuralgia only affect women? No. The pudendal nerve is present in everyone, and the diagnostic criteria are not sex-specific. Evaluation is the same regardless. My pain does not wake me at night. Does that rule it out? The opposite. Not being woken by the pain is one of the 5 essential Nantes criteria, so it supports the diagnosis rather than arguing against it. All my scans are normal. What now? Normal imaging is expected. The diagnosis is essentially clinical, with no specific test result confirming it, and imaging abnormalities that could explain the symptoms would in fact point elsewhere. Why would I have a nerve block if the diagnosis is not confirmed? Because the block helps confirm it. A positive response to an anesthetic pudendal nerve block is the 5th essential criterion, so the block provides diagnostic information as well as potential relief. Could this be something other than the pudendal nerve? Yes. Pain that is purely coccygeal, gluteal, or hypogastric falls outside the criteria, and neighboring nerves can produce overlapping symptoms. So here is the practical takeaway. If your pelvic pain is worse when you sit, if it does not wake you at night, and if your examination and your scans keep coming back normal, none of that argues against a pudendal nerve problem. It is closer to the expected picture. What it calls for is an evaluation against a defined framework, rather than being ruled out one normal test at a time. To have persistent pelvic pain evaluated, request an appointment at painmd.tv/appointment, call 314-481-5000, or text 314-886-5902. We have 2 locations, 4477 Woodson Road, Suite 100 in Street Lewis, and 12174 Natural Bridge Road in Bridgeton. No referral is needed, and you do not need to be an existing patient.